Hi, today I'm going to do a brief presentation about eccentric training as an intervention to Achilles tendinopathy. First of all, the introduction. Achilles tendinopathy is a very common pathology among athletes and ordinary people. Recently, there are some promising results about it, but the exact etiology of this type of injury remains unknown. Therefore, it is very necessary to research this topic further. Evidence for the intervention. I picked three journal articles. One is a systematic review, and the other two are randomized controlled trials. Their levels of evidence are based on a hierarchical system, which was invented by the National Health and Medical Research Council in Australia. The brief version is NHMRC level. So their level are in the system are level 1 and level 2, which is very high quality. First of all, let's look at the systematic review. First, search strategy. This systematic review I chose is a sensitive and a thorough search by reference tracking of the included study of 4 previous systematic reviews on intervention for Achilles tendinopathy. They did this just to make sure that no relevant studies were missed. Next, their search terms were appropriate too. For example, they used Achilles tendon, tendinopathy, tendinosis, tendinitis, tendon, exercise therapy, eccentric training, etc. The databases are also trustworthy, which are Medline, EMBase, CINAHL, etc. Risk of bias was assessed by the Corin Collaborations tool also. Let's talk about the inclusion and exclusion of the review. The articles must be RCTs or CCTs. The subject's mean age must be over 18 years. The condition must be mid-portion Achilles tendinopathy. And the symptoms must be chronic. The mean duration of symptoms must be over 3 months. And at least one group performing eccentric exercise training of the lower leg as a single intervention. Finally, they must be all have been published in peer-reviewed journal. The conclusions and the implications. The research group followed the findings and explained to me, to the audience, honestly. Let's move on to the 2 RCTs. The outcomes of Patrick scale of the two RCTs are the same, which is 8 out of 10. The 2 points they had lost are about blindings. But in this case, physiotherapists and patients cannot be blinded because the intervention must be seen and known by the therapist and the patients. It's not like drugs. Generally, the quality of the two RCTs are fine, but I listed 4 of their limitations. First, the group of researched subjects are relatively low. If they enhance the number of patients, I believe the outcome may be better. The patients start to quit months later, which is most unfortunate, which led to the long-term outcome less reliable. There were also concomitant interventions because they allowed crossover. For example, if they believe that the intervention they were trying was ineffective, they can cross over to other interventions. Finally, the comparison between eccentric training and shockwave treatment was impossible because the power was weak and the outcome measurement was lacking. Next part, I'm going to talk about the source of bias. The source of bias could be any of those I have listed. They are the patients and the examiners, or observers or the therapists, and the assessors may have biases. Too small pool of subjects. The choice of primary outcome. The outcome will be biased when they are seen by examiners. Fourthly, the possibility of concomitant interventions. Finally, a reducing number of subjects. Outcome analysis. Let's check out the 2 outcome analysis. Those 2 numeric outcomes clearly shows the difference, foreshadow what I'm going to say. 25% subjects in group 1, which is eccentric training group, and 64% in group 2, which are in the sound wave treatment group, scored 1 or 2 on the Likert scale, which means the general symptoms had been recovered pretty well. And in the mid-portion article, 60% patients in group 1 which is the same as the 2008 one, and 53% patients in group 2, and 24% patients group 3, which is wait and see group, reported a completely recovered or 2 much improved on the Likert scale. So this outcome means the majority difference between the two RCTs is that one focused on insertion of the tendon and the other studied the mid portion. The results are considerably different. This shows that the eccentric exercise, the Alfredson program, has less effectiveness on the insertion Achilles tendinopathy. Alternative interventions need to be developed. However, when treating mid-portion of the Achilles tendinopathy, eccentric training is still a useful intervention. Let's talk about shockwave treatment now. In the two RCTs, shockwave treatment has similar function compared with eccentric training. Both of them have significant effectiveness to the Achilles tendinopathy, at least to the mid-portion. The outcomes are follow-up. VISA A score, Likert scale, loading-induced pain, 1 to 11 numeric rating of VAS, and RS pain threshold. Both pain thresholds were both improved dramatically. So the perspective, although eccentric training is useful on treating mid-portion of the tendon, the insertional problem is still waiting to be improved. All of the 3 articles showed the expectations for more future researchers about Achilles tendinopathy. The systematic review and uniform outcome measure should be created. In the 2 RCTs, the choice of treatment, whether combined methods are better, is needed to be ascertained. Okay, the references. Thank you.